Well, good evening, everyone, and it's a great pleasure to be able to join you. I wish it was in person, but this is the next best thing. And first off, I want to just say good wishes to all of my wonderful colleagues in India, and I look forward to being there in person very soon. Tonight I'm going to talk a little bit about the 2017 American College of Cardiology, American Heart Association blood pressure guidelines, and just focus on some of the major recommendations, the rationale, clinical implications, and then hopefully we'll have some time for a dialogue. I have no conflicts of interest. The disclosures are fairly obvious. I've chaired the guideline writing committee, and I've chaired a number of the trials that have informed the guideline. So let's go to the next slide here, see if we can get back to work. There we go, sorry. Okay, so let's quickly say guidelines. I think for all of us they're common, they are useful, they do inform clinical practice. They're particularly useful in a setting like high blood pressure where the condition is common, practice patterns vary a lot, we know control rates are all over the map, and we've got a sufficient body of appropriately high quality evidence. In the United States, we've had guidelines for a long time. One of the earliest guidelines was actually in blood pressure, the Joint National Committee report in 1977. And then we had a series of these reports until 2003. That was the last JNC 7. And that then was followed by the National Heart, Lung, and Blood Institute deciding it was no longer going to produce guidelines, and they handed over that responsibility to the American College of Cardiology and the American Heart Association. Those two organizations quickly decided that for cardiovascular disease prevention, blood pressure was the area in which updating was needed most urgently. They spent about a year in outreach to other professional societies that are involved in the care of patients with blood pressure in the U.S. and then formed a writing group in 2014. They asked me to chair it. I was very honored. We spent about 2 years developing the guideline and then about a year getting review from all over the world and revising the guideline, and then it was approved by the professional societies. So you can see all the societies here. I won't go through them, but they include most people in the United States who would be involved in the care of patients with high blood pressure. The writing committee was multidisciplinary. About 75% were clinicians of both primary and specialty practice. We did have 2 lay patient members who were very helpful in forming our thinking, and we had a number of methodologists. We had an independent review committee, external review committee. We gave them certain questions and asked them to do a systematic review meta-analysis. We had very structured processes. It's a comprehensive report, so it's quite long, but we tried to deal with that by developing 15 sections and many subsections, trying to make them easy for clinicians to navigate if they have specific questions. In the end, we came up with 106 formal recommendations and a lot of evidence to support those recommendations, including 448 evidence tables. Each formal recommendation has what we call a COR, or class of recommendation, that really identifies the strength or importance of the recommendation, and an LOE, or level of evidence, what was the quality of the evidence supporting the recommendation. It went all the way from very strong evidence through to where there really wasn't good evidence, and we came up with expert opinion. And of course, much of medicine is based on expert opinion. As I mentioned, extensive review and eventual approval by the 11 bodies. So I'm going to touch a little bit on 5 aspects of the guideline: blood pressure measurement, blood pressure classification, approach to treatment, particularly in respect to when to use drugs, targets for treatment, and then strategies to improve control rates. We put a lot of emphasis on blood pressure measurement. It is what we would in the U.S. say is the elephant in the room. We've known factors that can lead to misrepresentation of average level of blood pressure, with getting measures that overestimate blood pressure or underestimate. And we know the factors that do that. Some of them are very predictable, or what we call systematic errors, and some are random. They just vary randomly from day to day, week to week, and we make recommendations to try to avoid those systematic errors and random errors. Unfortunately, in practice, these have not been followed well, with the result that there are, in most countries, including the U.S., poor quality measurements in practice. That's a huge problem because it leads to misdiagnosis, mistreatment, most commonly overdiagnosis and overtreatment. So it's important to try to get it right. We would close down laboratories who don't attend to quality control. We wouldn't fly on planes where the pilot didn't follow quality control procedures. But we've tolerated very poor quality measurements in practice. So what needs to be done is fairly straightforward, and unfortunately does require some time. Many times a physician might be too busy, but we can train either a staff member, and in our landmark studies, we never use physicians or nurses or pharmacists. We train regular staff members, or we can train the patient. But whoever does it needs to be trained, and it involves proper positioning of the patient, use of the proper techniques with the validated device and the appropriate cuff size, taking the right measurements, and then averaging the measurements, both within visit and across visits. And we recommend in this guideline and in most previous guidelines 2 measurements on at least 2 occasions to deal with random error. And then making sure the patient has the readings and an understanding of what they might mean. So that's important. We also recognize these days that what we see in the office is only a small window on what the body is exposed to, and many times the pressures we get in an office setting may be different to the pressures that we would see in somebody outside the office. Now, when they're the same, when you have high pressures in the office, high pressures outside, sustained hypertension, that makes life fairly easy, or of course if they're normal in both settings. The problem is that we frequently see a disconnect, either higher in the office and lower outside, so-called white coat hypertension, or more normal in the office but elevated outside, so-called masked hypertension. And both of these forms of hypertension are actually quite common, maybe in the order of 10 to 25%. We know that masked hypertension in almost all studies carries a risk for cardiovascular disease that is pretty similar to sustained hypertension. So when we wrote this guideline, we felt, based on expert opinion, that the individuals with masked hypertension might benefit not only from lifestyle improvement, but also maybe the addition of drugs. But that was only expert opinion. For white coat hypertension, we thought at the time we did this guideline that their risk was more similar to normotension than sustained hypertension. But in more recent times, there have been some studies, one very big one from Spain, published in the New England Journal of Medicine, that has suggested that there may be more risk attached to white coat hypertension. So for now, we have a dilemma. We don't have any clinical trials that help us to be sure what is the right treatment approach for white coat or masked hypertension. But we have to give our best estimates of what to do to patients. And clearly, with white coat hypertension, even if you decide to just follow with lifestyle approaches, a certain percentage will graduate to sustained hypertension every year. So both of these need to be followed very carefully. So there's certainly more to be done. In terms of classification of blood pressure, this has evolved over the years. In the US, it's become more structured. And starting in about 1993, all the way through 2003 in JNC7, we used the classification approach that I'm showing here. Let me just get the arrow. I don't seem to be able to capture that. Well, let's just say over here, this was the approach that was used typically in the United States. We looked at that very carefully based on the information available to us in 2017. And we decided that what was previously recommended as normal, less than 120 systolic or less than 80 diastolic, was perfectly sensible, and we should leave that as it was. We thought that the previous designation of hypertension for those with an average systolic above 140 or average diastolic above 90 was also very appropriate, and we should continue to call that hypertension. It was in this middle area, what would previously been called pre-hypertension, that we had some concerns, and particularly in the upper end of that distribution, the 130 to 139 systolic, 80 to 89 diastolic. We felt on the basis of risk and treatment experience that that would be better designated as stage 1 hypertension rather than pre-hypertension. And we just felt that the term pre-hypertension might lead somebody to believe that I don't have a problem yet. I'm prior to having hypertension, so I don't need to do anything or much of anything. And we didn't think that was correct based on the current information. We call the group below that 120 to 129 systolic and less than 80 diastolic elevated blood pressure. So the big change here is really stage 1 hypertension. And why did we call that stage 1 hypertension? Well, of course, in risk studies, in so-called cohort studies, you start by excluding the outcome of interest, and you look at the relationship of the outcome of interest with underlying blood pressure. There is a striking relationship for all cardiovascular outcomes, and it occurs at every age. It occurs in men and in women. It's there for systolic, as I show in this slide, but also for diastolic. And there is no evidence of a threshold for risk. It's a continuous relationship. Now, of course, these cohort studies do not include the types of patients that you would see in practice, many of whom have comorbidities. They might have some heart failure, they might have diabetes, they might have a little kidney disease. There are other studies that have looked at the relationship in that setting, and the biggest one is the one I'm showing here. It's a study from England that included about 1.25 million patients followed over a period of time. And I realize this is a much too small a slide, but this is 3 age ranges and a whole host of cardiovascular and mortality outcomes. And you get the picture that, again, there is absolutely a strong relationship throughout the range of blood pressure and no evidence of a threshold for risk. So either setting, you're going to find the risk goes up, and by the time you get to that systolic of 130, 139, or diastolic 80, 89, on average in these studies, risk for stroke and heart attack is about double. I want to show just a little more detail on risk here, going to an example from one cohort study. This is follow-up of the multiple risk factor intervention trial screenees. A large group followed in the U.S., about 350,000 adults, and they were followed for a pretty long period of time, close to 12 years. And again, just looking at the relationship between baseline systolic and cardiovascular disease outcomes. In this case, we're looking at coronary heart disease, but you could also look at stroke or other cardiovascular outcomes. In that range of 130, 139, there's close to a doubling of risk. When you look in this population and in the general U.S. population, that category, 130, 139, is quite common. It encompasses over 20% of all adults in the population. And so when you apply the risk to the number exposed, you would find that 130 to 139 really is important in terms of if the complications due to high blood pressure in the community. It represents certainly more than 20%, and for outcomes like stroke, closer to 25% of all of the blood pressure related events. So on a risk basis, this is clearly a very important category of blood pressure. It's just as important as capturing everyone with a systolic of 160 or above. Now, when you look at the treatment side, is there evidence that individuals with this level of blood pressure would benefit from interventions? Well, clearly there are a lot of non-pharmacological or lifestyle interventions that are beneficial, and we identified 6 ones that have been well proven. Weight loss, healthy diet, reducing sodium intake on the diet, enhancing dietary potassium through diet, physical activity, and moderation in alcohol intake. All of these in the blood pressure range we're talking about will give you somewhere in the range of 2 to 4 millimeters of mercury reduction, which is important. In combination, they'll give you much bigger reductions in blood pressure in the order of 6, 7, 8 millimeters of mercury. And I think anyone would believe, or most people would believe, that that would be very beneficial. We also know that low-dose pharmacological therapy in the context of high normal or pre-hypertension, that has been studied in 3 large trials, and in each instance, this sort of approach lowers blood pressure, prevents high blood pressure, and in the pre-VAR prevention trial has led to a reduction in left ventricular mass. So again, seems to be beneficial. And of course, later on I'll talk about treatment with antihypertensive drugs in the typical setting for hypertension, where you are starting at a higher level of blood pressure, but getting down to systolics below 130 seems to be sensible. So we thought, on the basis of risk and treatment benefit, that these individuals should be labeled more appropriately as stage 1 hypertension than pre-hypertension. Now, what about treatment? Well, some individuals will benefit from lifestyle change on its own, and some will benefit from antihypertensive drug therapy in addition. Now, like 90% of high blood pressure or hypertension seems to be due to poor diet and lack of physical activity. So, of course, improving lifestyle to get factors that I've just talked about is fundamental to the treatment of high blood pressure. And then the question is it sensible to add a drug in addition? Well, for everyone, a healthy lifestyle makes good sense. For those with elevated blood pressure, you can take it up a notch to try to help those individuals. But when we get down here to stage 1 hypertension, we felt for this group in particular, but for all hypertensives, it was important to have an understanding not only of their level of blood pressure, but the underlying risk that they would develop cardiovascular event over a period of time. And we used the AAJ-ACC 2013 pool cohort CVD risk equations. Those are easily available to you on the web at the American Heart or American College of Cardiology site. Actually, the ACC site is a little, I think, more intuitive and better. And we chose that for a couple of reasons. One, it's a decent risk calculator. It's not perfect in the context of hypertension, but it's a good one. And in the U.S., it's what's recommended for management of lipids and consideration of the use of aspirin to prevent stroke and other cardiovascular outcomes. So it made sense to use the same risk calculator that physicians are being asked to use for other reasons. We felt that it was particularly important in stage 1 hypertension to understand underlying risk. Of course, if somebody has already had a cardiovascular event, they're naturally at high risk. If indeed haven't had a cardiovascular event, and you do the risk calculation and they are not at high risk, then we would say lifestyle or non-pharmacological therapy is the sensible way to go. And that's about, in the US, about 70% of all stage 1 hypertension. For the minority, about 30% in the U.S., who are at high risk either because they've had a cardiovascular event or their risk calculation is over 10%. That is, there's more than a 10% chance that they will have a major cardiovascular event in the next 10 years. Then we would recommend the combination of drug therapy in addition to non-pharmacological therapy. We recommended formal estimation of risk for all hypertensives, but we said if you're an adult with high blood pressure and you concurrently have diabetes, you're almost certainly at high risk. And likewise, if you are an adult with chronic kidney disease and high blood pressure, you are almost certainly at high risk. So you can assume high risk, and even if you don't want to do a calculation, don't have the time to do a calculation, it is appropriate to treat them with the combination. And likewise, for adults over the age of 65, they're almost certainly at high risk, so they should get the combination. And we recommended that combination for all those adults with stage 2 hypertension, 140 or above for systolic, 90 or above for diastolic, independent of any risk calculation. And why did we really say, in addition to blood pressure, one should be looking at underlying cardiovascular risk? Well, there are 2 lines of evidence, really. One is when you look within a given blood pressure, in this case, let's say a systolic of 110, what you find is that the likelihood for having a major cardiovascular event varies enormously, depending on other risk factors. And it varies, as you probably know, more than 30-fold. And as you move from a lower pressure to a higher pressure, risk of having an event increases, but it doesn't increase much in the lower risk group. It really increases most in those who are already at high risk. So it's like saying if you want to rob money, where would you go? Well, you'd go to the bank because that's where the money is. If you want to prevent events, and that's the goal of treatment, where would you go? You would go to the people who are most likely to have events. So on a risk basis, this is a group that we'd want to be particularly focused on. When we look at treatment effect, again, it's interesting that across underlying risk of cardiovascular disease, the relative improvement in treatment with antihypertensive drugs is pretty constant. So the percent reduction in stroke and coronary disease, etc., pretty constant across these different pattern levels of underlying risk at the start. But when we look at the absolute benefit or attributable reduction in risk, it is very dependent on starting level of cardiovascular risk. And it's those individuals who have higher risk for an event that get the greatest absolute benefit. And of course, that's what patients should be most interested in, and what we should be most interested in thinking about our therapy. So again, the treatment was very consistent with risk estimation in thinking that we should be focused on high-risk groups. So in treatment trials, when we look at them and pool them, what we find is that what seems to be best is the extent to which we can reduce blood pressure and the starting level of cardiovascular risk. It is in this groups up here that are at highest risk, and this is the groups that we would identify with our calculator. These are the groups that are most likely to benefit from the combination of drug therapy in addition to non-pharmacological therapy. And so we came up with a number of algorithms in our guideline that try to walk one through how to think about treatment. And just going back to stage 1 hypertension, you would be identifying correctly individuals in this category, then asking, are they or are they not at high risk for a cardiovascular event? If they're not, non-pharm will reassess 3 to 6 months. If they are, non-pharm in combination with an antihypertensive drug, assess in 1 month, and then if they're not controlled, go further. Changing the classification system, we were aware that that would likely have a big impact on prevalence. And, you know, you can, of course, say, well, that's crazy, you're going to medicalize a lot of the population. On the other hand, you can say what we said, it's appropriate for people at high risk and where there's a potential to benefit them by reducing that risk, to be aware, even though it is going to increase the challenge for the clinical community. Because we're more focused on who should get a drug than we've been in previous guidelines, we didn't anticipate that we would have much of an impact on the use of antihypertensive drugs. We just thought we would provide an approach that would lead to better use of antihypertensive medications. What about blood pressure treatment? Well, I mentioned already non-pharmacological approaches for what we would do in the normotensive setting, but in the context of hypertension, we know they're even more effective. And of course, any intervention will have a greater effect on blood pressure at a higher starting level of blood pressure. So clearly, this is the underlying approach in most patients with high blood pressure. Drugs, when they're added, we felt the thinking pattern here ought to be, the first question is, do they have comorbidity that would compel you to choose a drug for that comorbidity that concurrently lowers blood pressure? In other words, you might, in somebody who's had a myocardial infarction, of course, want to use a beta blocker or an ACE inhibitor. ACE inhibitor here, for heart failure, there would be drugs that you would choose depending on whether it's HFpEF or HFrEF. So there might be reasons to choose drugs for the treatment of the comorbidity that will lower blood pressure, and that's job number 1. Where there was no compelling indication, then we felt very strongly that achieving blood pressure goal was much more important than the specific choice of drug therapy. There are differences between the drugs, but they pale in terms of importance compared to the importance of getting blood pressure down. Diuretics, long-acting diuretics in particular, and calcium channel blockers, non-dihydropyridine, calcium channel blockers in particular, are often very good choices. Our evidence review committee, in fact, suggested that the long-acting diuretic available in the US, chlorthalidone, was the optimal first-choice drug. But we felt that drugs from any of the following four classes were acceptable because they've all been shown to be very effective in reducing cardiovascular risk compared to placebo. Diuretic, especially long-acting thiazide agents such as chlorthalidone. I know in India that chlorthalidone may not be as readily available, but indapamide is another good choice as a long-acting diuretic. Calcium channel blockers, also very effective, and again, these are nice, especially if you don't have access to a laboratory, because they're metabolically neutral, so you don't anticipate electrolyte disorders. Angiotensin converting enzyme inhibitors are very effective, and we know angiotensin receptor blockers are also helpful. Not as many trials with them as with ACEs, and ACEs probably would be a better initial choice compared to an ARB. Certainly for somebody who doesn't tolerate an ACE, an ARB is a good replacement. Any of those four classes are acceptable. We thought initial combination therapy would be sensible in most patients, but we didn't dictate that. For instance, in patients with stage 1 hypertension, where they've only got a small reduction in blood pressure necessary, for somebody who wants to use a single drug, or somebody who is used to the step care approach of starting with one drug and then adding another, we felt that was okay. We did say that a combination of two drugs was very important in Americans who were black, African Americans, and adults with stage 2 hypertension who had a blood pressure that was substantially above target at baseline. We said that when you're using combinations, it is, of course, sensible to use logical combinations. A diuretic or CCB with an ACE or an ARB makes very good sense. They complement each other very, very well. We said it was good to use a single combination pill where that was feasible. We provided a list of everything that's available in the US. Unfortunately, many of the combination pills do not have the ideal combinations. And particularly for diuretics, they will typically, in our country at least, have short-acting diuretics or shorter-acting diuretics like hydrochlorothiazide, as opposed to chlorthalidone. So that's a shortfall. We said that in African Americans or US blacks with hypertension but without heart failure or chronic kidney disease, the initial treatment should include a thiazide-type diuretic or a CCB, because they tend to have volume expansion and benefit from diuresis. And the one combination that we knew should not be recommended for safety reasons was ACE and ARB, or two ACEs or two ARBs, because there's a high probability or possibility of hyperkalemia with that combination. What about the blood pressure during target, or the blood pressure target during treatment? Well, we'll start off by saying that all of the so-called event-based trials where you're looking at stroke, coronary heart disease, and other events as outcomes, we need to interpret them carefully. All of the landmark trials have been event-based trials. They are what we call efficacy studies. That is to say, they have tested the intervention under more favorable conditions than is typical in clinical practice, and we need to recognize that. The trials that have been done in selected samples, they're all including people who volunteer to be a part of the trial. We select people at high risk for having an event, and many of them have been done in the US or Europe, so they're overrepresented. Countries like India are underrepresented. China is indeed developing a lot of trials more recently, which is good for China. So we have to recognize these challenges, but despite that, randomized controlled trials do provide the best guidance for treatment decisions, including what the blood pressure target should be. And really, many clinicians, most in the US, like to practice evidence-based medicine. So if you're practicing evidence-based medicine that says conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. So if you are using that approach, then you have to mimic as much as possible the studies from which the evidence is coming. If you're looking at risk, most of our risk studies have measured blood pressure close to what guidelines recommend. If you're looking at clinical trials, they've measured blood pressure in that way, and they are, as I say, efficacy studies. So we just have to have that general caution as a background. And we have lots of trials, and since the prior guidelines in the US, a lot more trials and very useful trials. We have lots of pooling studies or meta-analysis that have looked at these trials. The largest of these meta-analysis is a so-called network meta-analysis. It provides the basis to include 42 randomized controlled trials with a lot of participants, and it gives you a lot of statistical power to look at randomized comparisons. And I'm showing you here a figure that illustrates what we found in this particular meta-analysis. And basically, what this is showing is that whenever the starting level of blood pressure that you're using as your control, as your intervention, a higher level of blood pressure is always going to give you higher risk. So the lower the blood pressure during treatment, in general, the better the risk seems to be, the more you reduce risk. And that goes all the way down to quite low levels of blood pressure. It's dramatic here for 120, 124 versus 160 or above. Over here, but it's even there for 120, 124 versus 125, 129. Not as dramatic, but still statistically significant. And this is showing it for all major cardiovascular disease events, but you see a similar pattern if you were to look at stroke specifically, or coronary heart disease, or all-cause mortality. And it doesn't matter whether you include specific trials or exclude them. Once you have 4 or 5 trials included in such an analysis, you're going to see very stable results. And again, it doesn't matter whether you use this network approach, which gives you more statistical power, or the more typical approach, which is a direct meta-analysis. You'll see the same pattern. And it's not just this study, which comes from our group at Tulane, but many others have shown the same sort of pattern. Now, in fact, we asked our evidence review committee to take a look at this for us, and they did a direct meta-analysis. It included a much smaller number of clinical trials, 19 randomized controlled trials. They came back to us and said, for what you're interested, 130 and below, yes, we see major benefits in terms of reduction of risk both for all cardiovascular disease, myocardial infarction, stroke, and heart failure. So we confirm what you're seeing from the other meta-analysis. So on the basis of all this information, we recommended less than 130 systolic as the target when you were treating patients. For most patients, to be helpful to clinicians, we identified an equivalent diastolic that the trials really these days focus on systolic. So this is based on very strong evidence. This one is based on expert opinion. For older adults, we said focus on systolic alone. Diastolic tends to be low. It's not what drives risk in this age, so your focus should be on systolic blood pressure. Now, what about subgroups? Well, of course, we worry about intensive reduction of blood pressure in certain settings, particularly in those who are older. And the trial that gives us the best information on the value or otherwise of intensive blood pressure reduction is the systolic blood pressure intervention trial, or SPRINT, which I should disclose I chair. We had interest in the number of subgroups in this trial. It is a large trial, more than 9,000 participants, and we selectively included a high percentage of individuals who were over the age of 75 had entry into the trial. About 2,600, a little over 2,600 participants, so a good number of participants, about 30% of the entire study sample. And we looked to see whether there was any indication that those who were over the age of 75 would have more difficulty with intensive blood pressure lowering. We didn't see it. There was no statistically significant difference between the effect of those under 75 at the outset compared to those 75 or above. And in fact, because the 75 and aboves are at higher risk for cardiovascular disease, they of course derive greater benefit. We went a couple of steps further. We said, well, what about the 75s plus who were the most frail or had the slowest gait speed? Those are the types of patients that clinicians worry about the most. When you're in practice and you see somebody coming in who is sprightly, you think they're probably relatively healthy. But if somebody is coming in and they're moving slowly, we all know that that is a very powerful indicator that they're at high risk for events. So we did two things. We used a frailty index to identify older participants at baseline who were the most fit, those in the middle less fit, and those who were what we would designate as frail. In each of those settings, intensive blood pressure reduction seemed to provide a benefit. Similarly, we looked at gait speed, which I'm not showing here, and it didn't really matter. Those who had the slowest gait speed, just like those who were the most frail, had the highest level of risk, but they benefited from getting their blood pressures down. So that was a very interesting and important finding in SPRINT. Likewise, when we looked at the J curve, this is something that has made us nervous about intensive reduction of blood pressure in patients with hypertension. And the J curve is something that we have seen, not in all studies, but in some studies. And it really comes from observational analysis. So many times you'll see trial, and then it's been analyzed not only for the randomized comparison, but somebody has taken the information and analyzed it as an observational study. And when you do that, you frequently see a J curve. And in SPRINT, we took a look at this. So looking by baseline level of diastolic blood pressure, and this is 5 categories, quintiles of diastolic blood pressure at baseline. And we looked at the relationship between baseline diastolic and risk for cardiovascular events, in this case the primary outcome, all-cause mortality, and we saw a J or U curve. We saw it in both the intensively treated group and the standard treatment group. Now, this intensive group was treated to a systolic of 120 or below, and the standard group was treated to a systolic of 140, below 140. So we saw that J curve there. But if you want to understand treatment, the real issue is, what do you see in a randomized comparison? And when we looked at this in a randomized comparison at every level of diastolic blood pressure baseline, we subsequently saw those who were randomized to intensive blood pressure have lower levels of risk compared to their counterparts with systolic pressure. In fact, because risk is highest in this lowest category of diastolic, that's where there seemed to be the greatest benefit to individuals. So, again, just like I showed you for older individuals, the information would suggest that lower is typically better, both for the primary outcome. We saw the same thing for J curves with observation analysis and low risk for randomized comparisons here. So what this is suggesting is that overall lower is better. Obviously, we need to be sensible as clinicians. We need to monitor our patients carefully to see if they have any problems, and I would say symptoms are more important than measurements. Frequently we see people who have relatively low pressures, and their body is going to tell them whether that's a problem for perfusion of the organs. If they're coming in and saying, I've got syncope, I'm dropping to the ground, or I'm feeling dizzy, of course we know that's a symptomatic problem, and we probably need to cut back on the treatment. But the risk of issues like syncope and falls and hip fractures, as much as they are a legitimate concern, should not prevent us from providing what is very clearly dramatic benefit from those at highest risk. So that was a useful learning point. And the next thing I want to go to is diastolic, next thing I want to go to is diabetes. And we've been uncertain here as to how low to take the blood pressures. Now, actually, one of the first randomized control trials that ever looked at more intense versus less intense blood pressure was done in diabetics. It was reported many years ago in 1999 from the United Kingdom. And it showed that getting to lower levels of blood pressure compared to higher pressures provided tremendous benefit in terms of stroke, diabetes endpoints, diabetes death, microvascular disease, whether it be retinopathy or neuropathy. So very dramatic effects, much more dramatic, for instance, than lowering glucose, or where we get about a 10% benefit from tight versus usual control. Of course, the pressures that were considered intensive blood pressure at that time are now what we would consider we would have considered in the past relatively standard. So we've changed the norms. But nonetheless, this was a study that showed lower was better. And we've gone on to have many other studies, and most recently the largest study to look at this question was done in diabetics. It's a good study. It's a study called the Action to Control Cardiovascular Risk in Diabetes Blood Pressure Trial, or ACCORD-BP. Not as big a Sprint, about half the size of Sprint, but just like Sprint, they got a good lowering of blood pressure, maintained that difference between the intensive group and the standard group throughout follow-up. And then when it got to looking at the outcomes, the primary outcome, like Sprint, was a composite of a number of cardiovascular outcomes, and it did not show statistical reduction in risk. So the more intensive treatment was not proven to be beneficial over standard treatment. Of course, when you looked at the confidence interval here, it was pretty wide and suggested that, well, there could be a worsening of risk with intensive treatment, up to 6%. Most of the confidence interval was below 1, suggesting that there might be a benefit. So down here, you could go to a 27% improvement. The true benefit, or the true effect of treatment, is probably somewhere within this confidence interval. The best estimate suggested a benefit. The confidence interval certainly included the possibility of a benefit. So it was a negative study, but it was really one that didn't really answer the question. And unfortunately for the investigators, they got much less events than they were expecting. They were expecting in the standard group here to get 4% per year cardiovascular events. They ended up getting 2%, and that really diminished their power, statistical power, to answer the question. They did get a secondary finding, stroke, that achieved statistical significance, but not a very large number of events, and it is a secondary finding. One other issue with the accords, when you pull sprint and accord, they seem to be pretty similar, suggesting that it's really confidence interval is the issue and not having enough power in accord. One other issue that may be important with accord is they used a design unlike sprint, where sprint was a sort of a classic two-arm parallel trial, easy to interpret, hard to get wrong. Here they used what's called a factorial design. So they were trying to answer more than one question. So for the blood pressure trial, they had participants randomized both to glycemic control, intensive versus standard, and to blood pressure control, intensive versus standard. And when you do this sort of study design, you make some assumptions. And the assumption is that there's no interaction between this intervention and this intervention. And you never can be sure about that assumption. There's not good ways to test it. We have statistical approaches to testing it, but they're not very robust. You can look within cells for only blood pressure intervention occurred, or likewise for glycemic control, but you're now reduced in power, and it's a secondary analysis. So that analysis has been done for intensive blood pressure. If you take out the group that got the glycemic control and just had standard glycemic control and compared intensive blood pressure with standard blood pressure, then again there was a suggestion for improvement, very consistent with sprint. And so I think accord is a bit confusing, but to me it is perfectly consistent with sprint. It doesn't prove the benefit in diabetics, but it's consistent with the benefit in diabetics. Many studies have included diabetics and have suggested that lower is better. And when you pool these studies and do what's called a meta-regression analysis, overall the benefit for intensive treatment for most outcomes seems to be pretty similar in diabetics compared to non-diabetics. Now, in sprint, we did not have diabetics. Diabetics were excluded because accord was going on as a trial. But we did have the ability to look at those who were on their way to diabetes, the so-called pre-diabetics. And it didn't matter whether you were looking at normal glycemics or pre-diabetics, the pattern for benefit in terms of the primary outcome and death from any cause was essentially identical. So sprint didn't inform us directly with respect to diabetics, but it did inform indirectly, because in pre-diabetics we saw the same benefit as we saw in normal glycemics. What about chronic kidney disease? Another area where we've been uncertain how much to lower blood pressure. There are two questions in chronic kidney disease. One is, does the treatment improve kidney function? And the second question is, does it improve cardiovascular outcomes? Because most patients with chronic kidney disease don't die from the kidney disease itself. They die because they're at very high risk for cardiovascular disease. They have many risk factors that lead to cardiovascular disease, and that is the most common cause of death in a patient with chronic kidney disease. So, what do we know about chronic kidney disease? Well, we know in most of the intensive reduction studies that we haven't really improved kidney function, and perhaps that's because these trials haven't been able to follow patients long enough. We tend to stop these trials, as with SPRINT. But if we look within studies like SPRINT, where again we made a concerted effort to have a lot of patients with chronic kidney disease, and over 25% of our cohort had chronic kidney disease at baseline. It didn't seem to matter whether they had chronic kidney disease or they didn't have chronic kidney disease. They did equally well in terms of benefit from intensive blood pressure reduction. And that seemed to apply to all of the major components of the primary outcome, as well as, all the major components of the primary outcome. So here we're looking at the entire cohort. Here we're looking at the experience in those with CKD at baseline, and you'll see they're remarkably similar. So it suggested to us, based on SPRINT, that intensive blood pressure reduction was beneficial in terms of cardiovascular outcomes for the patients with CKD. We did not see an improvement in chronic kidney disease. What about adverse effects during intensive blood pressure treatment? I think we know now from the studies that intensive blood pressure reduction improves cardiovascular outcomes and probably all-cause mortality, but do you get side effects, and do they diminish the enthusiasm for treatment? Well, of course you're going to get side effects. Whenever we treat, there is the potential for a side effect. The question then is, how serious are these side effects? How common are they? Well, most likely side effects would be electrolyte abnormalities. You're using more drug, and particularly as you use more diuretic and more ACE inhibitors, you're likely to see some electrolyte abnormalities, hyponatremia, hyperkalemia, hypokalemia. Statistically, there will be a difference between treatment groups randomized to intensive versus standard. Not very common, but it does occur, and we need to be cognizant of that fact. And if you're using drugs that can affect electrolytes, then it's very important to monitor them carefully for electrolyte change. And then you can react to that by lowering dose, dropping that drug, substituting, if it's a diuretic, perhaps substituting a CCB, etc. So we can expect this as a possible side effect. Reduction in estimated GFR has occurred in almost every trial where it's been studied during intensive blood pressure lowering. Now, it's statistically significant, but it is relatively small. For instance, in the SPRINT study, in those who started with chronic kidney disease at baseline, the overall difference between the two treatment groups was about 3 mils per minute per 1.73 meters squared body surface. So not huge. Take somebody a little closer to the cliff, and so if they had an intercurrent problem with loss of volume or something like that, maybe it puts them at a little higher risk, but not much. It has not resulted in end-stage renal disease or significant important reduction in estimated GFR in any of the intensive treatment studies. In SPRINT, the participants with CKD at baseline had a reduction, particularly in the intensive group, very early on. But once you got out to about 6 months, then things were pretty stable in terms of the slope for the standard group versus intensive group. So there's a continuing reduction in estimated GFR, but it is an age-related reduction with a similar pattern in both treatment groups. So we need to be cognizant that GFR will go down a little bit, but many people think this is a hemodynamic effect, and that actually it may be in the long term beneficial for the kidneys. There's a recent trial that has just been stopped. We don't know the details. It's a study of an agent for treating diabetes that also tends to do the same, reduce GFR. And in long-term follow-up, that trial was stopped due to benefit in terms of kidney disease and cardiovascular events. So that's going to be an interesting trial to look at. It's not a blood pressure reduction trial, but it is dealing with that thesis that maybe a reduction in GFR is not a bad thing. Maybe it's a good thing. Maybe it helps to protect the kidneys. So we don't know for now. You have to be cognizant of it. We have to follow it. What about serious adverse events? Well, we define serious adverse events as the U.S. Federal Drug Administration defines them. They tell us that's how they want them. And their definition is fatal or life-threatening event resulting in significant or persistent disability, requiring or prolonged hospitalization, or judged important medical event by the physician of record. And many trials really don't give you good information on SAEs. SPRINT gives very good information. Almost all the SAEs in SPRINT have been due to a hospitalization. So the physician sees somebody with an issue, whether it's electrolyte abnormality or a change in GFR, and they decide in the best interest of that patient they should be hospitalized to take a more careful look. In SPRINT, when we compare the intensive and standard treatment groups, overall there was no difference in SAEs or serious adverse events between the two treatment groups. The SAEs that were more common in the intensive group were primarily, as I mentioned, due to hospitalization. And those hospitalizations associated with hypertension, syncope, electrolyte abnormalities, or acute kidney injury or renal failure. And these are pretty frightening terms, but that's just the term that's been put on the discharge diagnosis or the admitting diagnosis, and it doesn't really tell you that these are serious irreversible problems. Now, we have looked at the issue of those who got admitted for so-called acute renal injury or renal failure in SPRINT, and I'll show you a slide on that in a moment. Now, I would just say these so-called complications have to be interpreted with caution. One, because of the way in which we interpreted them. For the beneficial outcomes, it was a very appropriate comparison of like with like. For adverse events, because that's so important to an individual, we took an adverse event whenever we would see it. So we know that we introduced bias in looking at adverse events, including serious adverse events. We had 30% more visits in the intensive treatment group, and it's an open trial, so there's almost certainly over-reporting of adverse events. And the AKI study suggested that most of these events were fairly, I wouldn't say unimportant, but they were not hugely problematic. So when we looked at those who were admitted for acute kidney injury or acute renal failure, the vast majority of them, shown here in red, had the mildest. I had only one event during the entire trial. The vast majority of them had the mildest form of AKI, whether they were with or without kidney disease at baseline, and the vast majority recovered fairly quickly. So, yes, they were admitted for a so-called kidney problem, but it was a one-time issue. It was pretty mild, and it seemed to resolve. Now, I don't want to diminish the importance of monitoring for side effects, but again, I just want to say we need to balance the beneficial outcomes, which are pretty dramatic, and the adverse outcomes, which are important but seem to be of much less consequence. So we shouldn't be stuck in cement, afraid to treat because of the fear of adverse events. We should treat to provide benefit and monitor carefully to recognize and manage adverse events. Even if you weighted the benefits and the adverse events equally, which I don't think is appropriate, but even if you did that, you would come to the conclusion that others have come to, that it's still beneficial to treat at the typical, in the typical setting for healthcare provision. And of course, a good clinician is going to monitor carefully and can manage and mitigate adverse effects by reducing dosage, maybe substituting drugs, etc. So those are the targets overall, and for specific subpopulations of particular interest. And how are our targets in the US-AHA-ACC guideline compared to others? Well, we're a little bit higher than what the Canadians and the Australians recommend. They made a recommendation of systolic 120 or less in both instances based on the SPRINT study findings. They gave it the highest recommendation in the Australian and in the Canadian based on a single study. Would be grade B would be the highest they could give. And they both said, well, of course, if you're going to do intensive blood pressure management, you need to monitor the patients carefully. In 2017, the American Diabetes Association came out with a statement, and they suggested treat all diabetics or adults with high blood pressure to at least less than 140/90 and to less than 130/80 in those who are at high risk for cardiovascular disease. And I will tell you that that is almost all diabetics who are adult and have high blood pressure. So pretty consistent with what we've recommended. European guidelines from the European Society of Hypertension, European Society of Cardiology were presented recently at the European Society of Hypertension meetings. They will be presented again on August 25th at the European Society of Cardiology, and the publication of these guidelines will be concurrent with this meeting. But based on the presentation at ESH, they're not changing the definition of hypertension, is sticking with 140/90, but they are saying for the group we would call stage 1 hypertension, and they will call high normal blood pressure 130, 139, or 80/89 for diastolic. Similar recommendation to us. Treat with lifestyle and in addition consider antihypertensive drug therapy. So when you get past the semantics of definition, our recommendations are largely very similar to what the European recommendations will be. And I just want to show here concordance, and this is what the American Diabetes Association, let me just say, when we look at these guidelines, frequently what happens is people publish a paper and they say, they focus on the difference, and then it confuses the heck out of clinicians and out of patients, and of course the newspapers love controversy, so they'll highlight it, whether it's the medical newspapers or the general newspapers. I find that very frustrating, and I think we should be looking at similarities rather than differences. And for instance, when you look at the American Diabetes Association, what to do in adults with high blood pressure who have diabetes, our recommendation and the ADA recommendation are very, very similar. So in most patients, in this group here, the white group, that is where neither of the guidelines would recommend treating to more intensive goal. In this dark inner circle is where we would both recommend the same thing. And the difference is here, where it's recommended in AHA-ACC, but not the diabetes guideline. You can see it's really very small. So concordance in about 96% of the patients. Last thing I want to talk on briefly is hypertension control rates. And we have a problem with hypertension control, even at, this should be 140 over 90. I apologize, that's a typographical error on my part. Even when we've been looking at what was previously recommended, systolic less than 140, diastolic less than 90, no one is doing well. We and the Canadians are doing about the best. This is what you see in the US general population, about 52-53% overall control to less than 140 over 90. But here's what we see worldwide. My colleague, this is a paper from my colleague Catherine Mills. We looked at this in 2000, and she's updated it with a very nice study looking at worldwide prevalence and control rates for high blood pressure, and you'll see that worldwide we're at a very dismally low rate of control, less than 14%. And in fact, when you get into this is buoyed a little bit by the higher income countries. When you get to low and middle income countries, it's shocking. It's less than 8%. So collectively, we all have a lot of work to do. Well, we know here in the US that we can do a lot better than this sort of control rate. We know that from clinical trials, or we can control almost anyone, even down to 120 systolic. And we know that in many practice settings, particularly in the US where we've got good practice groups and they are managing insured patients, they do a lot better. They can get up to 90% control rates at the 140 over 90. We've tried to learn from best practices. What is it the studies, the groups that are really achieving these sorts of control rates are doing that is helping to get better control? Well, starting with very simple things, adherence strategies. There should be no reason in managing a patient with high blood pressure to use any medication that is more than once daily. And where at all possible, we should be trying to use combination pills. We should be encouraging strategies to promote lifestyle modification. You know, that improves control rates. A really big one in the US has been team-based care. The team obviously starts with the patient and the healthcare professional, but it can be, the healthcare professional doesn't have to be a physician. We know that physicians in the US are really busy. There are a lot of other things they've got to do that require their expertise. We know that nurses and pharmacists are excellent in managing high blood pressure. And so extending the team to include either nurses or pharmacists really improves control rates. The team can be further expanded to take advantage of office staff and community health workers. The office staff can keep a track of who's showing up, who's not showing up. They can do other simple things, inquiring about adherence, etc. And then involving others, spouses, relatives, friends. This has been, in U.S. studies, the most powerful intervention to improve control rates, so it's a really important one. Use of the electronic health record is helpful where it is used actively. Now, passive use of the EHR or the medical health record or the hospital record, whatever you call it in your setting, passive use is not going to do a darn thing. It's when you use it actively and you create a patient registry to track people. How well are they doing in their control? How well are they doing at showing up for visits? How well are they doing at taking their meds? That's where it really becomes helpful. Likewise, telehealth strategies, where you're getting information from outside the office and it is being electronically fed back. That can be quite helpful. Use of performance measures and quality improvement initiatives are helpful. Financial incentives have a statistically significant effect, but not a big effect. Particularly impacts clinicians, but even there, clinicians are not in the settings in which these studies have been done, at least, driven by compensation. So these ones are the big ones up here, and they can lead to much, much better control rates. So to summarize, I talked about our guideline. It's a rigorous guideline. I'd like to think it is getting all of the most up-to-date information prior to the publication of the guideline. We strongly suggest the importance of accurate blood pressure measurement for diagnosis and management. We recommend a diagnosis of hypertension for an average systolic of 130 or above or diastolic 80 or above. We strongly recommend lifestyle modification as a core strategy to lower blood pressure. And we recommend addition of antihypertensive medication in stage 1 hypertension, where there is a high underlying risk for atherosclerotic cardiovascular disease, and for all individuals, stage 2 hypertension. We recommend a target during treatment of a systolic blood pressure less than 130 millimeters of mercury. We provide an equivalent for diastolic of 80, but systolic is the more valuable endpoint, and it's the only one that we recommend for older adults. We recommend a number of strategies to improve blood pressure control, and we are strongly of the belief that adoption of some or all of the recommendations in our guideline are likely to confer major health benefits. And I'll just end with one slide here that compares what would be expected in terms of benefit within a year in the United States if our guideline were to be followed compared to a previous guideline. This is the 2014 JNC8 panel members' recommendation. So you see big differences in what could be expected, and this was published by a group independent of our guideline committee, and we have several publications that are showing the same sort of outcomes as well. So I thank you very, very much. It's been a pleasure to chat with you, and now I look forward to a dialogue and interchange, because, of course, some aspects of this guideline are very transferable. The guideline was written for the United States. Something transfer well. Measurement of blood pressure is the same problem for all of us worldwide. Gold blood pressures probably transfer pretty well. Risk estimation does not transfer so well. We know that. So some aspects of our guideline may be very helpful to you. Some aspects may not be as useful to you. But I look forward to an exchange and dialogue with you in the remaining time. Thank you very, very much. okay on the other end? I'm waiting to get questions. Can you shift this to the questions? Thank you. Any questions? Any comments? I'd be happy to get them. I will say, of course, just as we're waiting, that we would all like to have guidelines that involve all components of those who are involved in the management of high blood pressure. And I remember back to the days where we had few, if any, guidelines, and we were all operating on the same guidelines. Sadly, those days have passed. There's many different groups producing guidelines now, and as I mentioned earlier on, when those guidelines come out, the natural instinct is to look at differences and to really highlight those differences rather than to look at similarities. And I think that that is a big issue. There's nothing we can do about it except what we're trying to do now, take our guidelines and compare them to others, see where there are differences, see where there are similarities, and try to highlight the similarities and try to understand where the differences occur and whether they make sense or not. But I think now we have the major guidelines coming out, the European guidelines and the American guidelines, the ACCAJ, are probably the two most influential guidelines. There are guidelines that will be coming out from a number of other countries. I can't speak to India in particular, but I am aware that China is working on guidelines. I probably will come out within the next year. I am aware that Japan is working on guidelines, and it will probably be updating in a year. Both China and Japan have wanted to wait till they saw what was in our guideline and in the European guideline before they would decide what to include in their guideline. And it would be interesting, obviously, to see the European guideline in print. I think we know enough about it from the initial presentation that we can say there are some differences, quite understandable, quite natural. We expect that. But there are much more in the way of similarities than there are differences. We are both recommending care in the measurement of blood pressure. We are both recommending similar management. We are both recommending lower targets during treatment than was previously the case. So there's a lot in common. I would say in our guideline as well, we provide a lot of information that I haven't covered today. So we certainly do a lot vis-a-vis people with underlying cardiovascular disease, whether it's stroke or it's stable ischemic heart disease or it's heart failure and so on. We talk about different groups, older people, diabetics, those who are pregnant or likely to become pregnant, etc. We provide recommendations around urgent care, hypertension that is an emergency versus hypertension that is urgent. And the difference there would be, is that very high pressure accompanied by ongoing target organ damage? And only when the very high blood pressure is associated with ongoing target organ damage would it be sensible to contemplate intravenous reduction in blood pressure. And we also talk about so-called resistant hypertension, most of which is not truly resistant, it is apparently resistant. And we give, again, algorithms how to manage all of these areas. And we have at the end of our guideline a general approach to how to manage the patient with high blood pressure. So I hope you will have found this lecture to be useful, and I hope that you will find our guideline to be helpful and that you will find it easy to navigate, although it is large. You can go in and essentially, I hope, find an answer to almost any question that you might have. And hopefully we'll have an opportunity to meet in person in India, or if you come to the US, I look forward to seeing you in the US. It's been a pleasure being with you. Any questions? Amanda, do we have any questions? Okay, well, hopefully we didn't have a lot of questions, so hopefully it was clear, and it's truly been a pleasure being with you. I thank you for joining me in what has probably been a busy day for you and a long day for me, early in the day for you and earlier in the day for me. And thank you again. Look forward to seeing you soon.